Hey, everybody, and welcome. I'm Ryan Hampton, and this is another great conversation we're having as a part of our Operation Understanding initiative. Operation Understanding is a project we're running at Mobilize Recovery to close the gap, the critical gap between the people making decisions about addiction and recovery and the folks like us who are living the reality of it every single day. If you followed us for a while, you know the whole idea around this concept is understanding, not just this year, but every year that we're involved in this work. So we're not here scoring points. We're not trying to shout past each other. We're just getting real and authentic about what actually helps people get well and to stay well and to remain in sustained recovery. And today's conversation, is one that I've been genuinely looking forward to for some time because we're going to spend some time on what I believe is one of the hardest, most overlooked corners of the entire overdose crisis, and that's the criminal justice system. Jails, prisons, the moment that somebody, walks out from beyond the walls. It's a place where the science of recovery and the reality on the ground are oftentimes and sadly miles apart, and we're going to dig into why and what that actually looks like to fix it. And my guest is Ann Wheeler with Indivior. Indivior is a company that spent a lot of time and resources and research in this space working to modernize how we treat opioid use disorder. And Ann, I'm really grateful on behalf of Mobilize Recovery that you've been able to carve out some time to spend with us. Welcome.
Thank you. It's my absolute pleasure to get to join you today, and I'm really looking forward to our conversation.
Fantastic. So before we dive into some of the more heavier stuff, the data, the policy, all of that jazz, I want people to know a little bit more about who they're listening to. So can you tell us a little bit about yourself, what your role is at Indivior, maybe most importantly, what really pulled you into this work? What is your why in the first place? Was there a moment for you that this kind of really stopped being a job and got real personal?
Yeah, no, I appreciate that. And it is very personal. So again, I am with Indivior. I'm the chief medical officer, and it's my distinct honor working with our medical affairs, safety, and regulatory teams. My background is in clinical psychopharmacology, but what brought me to this work originally was the opportunity to have a tangible difference in the lives of patients who face some of the most challenging and stigmatizing health conditions, and that's with behavioral health. Early in my career, I was drawn into psychopharmacology because of the effect that medications can have on an individual's ability to function, to heal, and reclaim their lives. And then as I gained more experience in this area, I became more and more aware of the devastating impact that substance use disorders, and particularly opioid use disorder, can have not only on patients, but also on their families and the communities where they live. So seeing both the unmet need as well as the barriers that people often face in accessing evidence-based care really reinforced my conviction that this is where I could have the greatest impact. So while there wasn't maybe really a defining moment in my career, it was more of a series, I guess, of experiences of caring for and learning from people whose lives were transformed by effective treatments and when they were made available to them.
Incredible. I mean, is there, folks oftentimes in like the medical field, right? And pharmaceutical field and hospital field, started in one place on like what their thought of addiction was or is. And through their career, their professional, either their learned experience or their own lived experience, there's been a reframing of how they feel about it. Did you kind of start in that same place? Like before you got into this work, did you have one view of what addiction was? And now, years later, it's completely reframed given all the work that you've done around it and the people you've met, and the experiences that you've lived through?
Yeah, definitely. So, starting out in my career, I would say I was very focused on treatment protocols, and now it's all about individuals and patients and how to best support them. In Indivior, we have some amazing patient ambassadors, and learning through them, it really points to the fact that recovery is possible. So rather than looking at treatment protocols, it's more about how can we impact true recovery in patients' lives.
So for folks who've never heard of Indivior, you've probably, if you've been engaged with Mobilize Recovery, you've heard the name, you've seen the brand around some of the work we've done. They've been a huge supporter of Mobilize Recovery and many folks in this space for a long time. But I was wondering, Ann, if you could, maybe describe the company a little bit, what you're actually trying to accomplish in the space. And given your experience, if maybe you can give it to us in plain English.
Sure. Yeah, absolutely. And I'm very proud to work for Indivior. And Indivior is a pharmaceutical company that's dedicated to helping people recover from opioid use disorder. So by developing innovative medicines and modernizing how treatment is delivered and accessed, we work to ensure that people can receive effective care and achieve long-term recovery while they're reclaiming their lives. So what drives our mission is the recognition that opioid use disorder continues to impact individuals, their families, and communities across the country. And people are continuing to face barriers to treatment. They're continuing to face stigma and fragmented care. So at Indivior, our commitment is to help break down those barriers, supporting broader access to modernized evidence-based treatment and advancing a recovery approach that gives people the opportunity to not only survive, but really to rebuild their lives and to thrive. Our goal is to contribute to a future where opioid use disorder is recognized and treated like any other chronic disease, with compassion and with urgency, and definitely with the highest standards of science.
It's a great answer, and we're going to get into this a little bit more shortly. But I have the exact same values I think that you do, and that the company holds, and to really change the trajectory around how we not just treat opioid use disorder, but the support that we give people to maintain sustainable recovery. It takes it doesn't just take one vertical. It takes government. It takes nonprofits, it takes companies, it takes advocacy work, all working together.
Yep.
So, I want to give a little bit of my side too before we jump into some more of the deep questioning and where I'm coming from. So Mobilize Recovery, really started because I got tired, and many people in our community got tired of recovery advocacy being, something that just happened to us instead of with us. We spent years building a community of people in recovery, family members, allies, folks who have been impacted, folks who are in the rooms and, been through the system, and turning that into real muscle for an advocacy movement. And one thing, that we keep running into over and over is access. People want to get well. People want to get better. The medicine exists. The science is there. The data backs it up. And somewhere in the middle, it feels like, too often than not, that door to access tends to be locked. And that's the gap, that I care about. And I know that many in our community and advocacy network care about. And that's, why I believe this partnership with Indivior in this conversation really matters. So, from the corporate standpoint, and like when you think about where, a company like Indivior and a movement like Mobilize Recovery really line up, where does the overlap feel, strongest to you? Where, do a company and an advocacy community actually need each other, to move the needle forward in a positive direction?
Yeah, absolutely. I think it's a fantastic question. And as a clinician, I've learned so many important lessons that have come from individuals rather than from journals or from conferences and lectures. It really does come from people who have a lived experience with recovery. And that's why I personally view, and I know Indivior views advocacy as an essential partner. Where science can tell us what works, lived experience actually tells us and helps us understand what makes it work actually in people's lives. So I would say that the opioid crisis is much too complex, obviously, for any one organization to solve. And our real progress is going to come when our researchers, clinicians, advocates, policymakers, families, people in recovery all work together towards the same goal.
Yeah, absolutely. So let's set the table for folks who are listening and joining us, because I think a lot of people don't realize just how big and astronomical, this problem is before we start talking about the jails and the prisons. When we talk about opioid use disorder in the United States, we're not talking about really a niche, issue, a fragmented issue. We're talking about something that's touched in some way almost everyone, if not everyone. So, give our audience a scale of this. When you look at, the national landscape of OUD right now, here in 2026, the human cost, the economic cost, what are the numbers that really stop you in your tracks the most?
Yeah, it's truly staggering when we look at these numbers. So national data shows us that roughly 8.9 million or almost 9 million people misuse opioids each year. And of those, only 4.8 million are diagnosed with an opioid use disorder. So That's a huge discrepancy in my mind. And the staggering reality is that we know that there's about 80,000 preventable deaths that happen each year, and it is the leading cause of death for the 18 to 25-year-old population. In 2024, it was estimated that the total societal and economic burden of the illicit opioid epidemic in the U.S. was around $2.7 trillion, or close to GDP.
Wow. And when I get in front of policymakers, right, and people and folks who are, in kind of the think tank world of this, and try to make the economic argument to them, or try to make the human argument to them and the healthcare argument to them, if they're not convinced, I then switch to the economic argument, right?
Yeah.
Because when you talk about that $2.7 trillion number, right?
Yeah.
Like you said, 10% of our gross domestic product here in the US, it almost feels too big, to be real. And when you talk about the long-term savings that we could have to bring that 2.7 trillion number down, to lessen the burden on our economy and the economic impact of untreated opioid use disorder in the United States, if there's no other reason that somebody believes we should do this, it's certainly that. So, what are we paying for really, when we don't treat this well? There are long-term impacts that hit people in their pocketbooks. So, one thing I want to make sure we hit on in the front end of this conversation, because there's still so much stigma around it. And I'm someone who early in recovery, if it hadn't have been for Suboxone, I'm not sure if I would have made it. Suboxone and buprenorphine is a big part of my early recovery story. And I want to address it, is the medications, because there are still a lot of people out there, including people who are in positions of real power, who think that medication for opioid use disorder is just kind of substituting one drug for another. They call it a crutch. And I have a lot of real feelings about that I've aired in many venues. But I want to give you the floor on this issue for a few moments, because I really feel that it's important for us to address.
Yeah, I really appreciate that. I want to thank you for bringing attention to it. And I do understand why there's confusion that some people have, because the medications interact with the same receptors, right? They interact with the opioid receptors in the brain. But that's about where the similarity largely ends. Addiction isn't simply whether there's an opioid in somebody's body or not. It's characterized by compulsive use, despite the fact that there's harmful consequences associated with it. It's a loss of control. It's craving. It's a cycle that increasingly disrupts a person's health, their relationships, and their ability to function. So the medications that are used to treat opioid disorder are designed to do the opposite of that. They stabilize the brain, they reduce cravings, they prevent withdrawal, and they allow people to function more normally. And this allows people to then return to work, to care for their families, to pursue the goals that they have, and engage in their own recovery. So when the treatment's working, we're not seeing people become less functional, we're seeing them reclaim their lives. If we're diving a little bit deeper, I guess, into the pharmacology and how these things work, when we see people use opioids chronically, it changes the way their brains affect the reward, motivation, stress responses, and their decision making. So as opioid use disorder develops, people often aren't using opioids just to feel good anymore. They're using them to avoid feeling absolutely terrible. So medications like buprenorphine can help stabilize those disrupted brain circuits, and they occupy the opioid receptors in a more controlled and sustained way, thus reducing withdrawal symptoms and craving without producing that same cycle of intoxication and reinforcement that drives addiction. And this gives people a real chance and opportunity to focus on their recovery.
Yeah. And, you just gave a really good clinical rundown of it. And I'll tell you, for me, my brain needed time to heal. Access to, Suboxone for me gave me that period where I was really vulnerable in early recovery, for my brain to actually have that time to heal, and for the medication to help it heal, and for me to make better decisions, and for me to be able to engage in my treatment process more, and for me to be able to go back to work and reintegrate into my community. And quite frankly, I credit that and being able to have access to safe, stable recovery housing afterwards as the reason I'm coming up on 12 years now in recovery. I had gone through multiple treatment episodes, about a half dozen, 6 of them, before my 7th treatment episode, where the 6 actually denied me access to any type of MOUD especially buprenorphine. And it was that seventh opportunity and last opportunity I had at treatment. It was a public treatment center too, that put me on a protocol of Suboxone that really saved my life. So I am a huge advocate. I think that more people need to understand the science behind what happens in the brain, actually. When people take these medications, I think, we at Mobilize Recovery are doing as much as we can to bust the myths, around this, because quite frankly, this is one of the best pathways we have out of this crisis. And, there's a whole menu of medications people can take. It's buprenorphine, methadone, naltrexone. Now there's new long-acting injectable versions. We were just with a treatment provider yesterday, meeting with them, and they're offering, Sublocade, which has become a great tool for them and has really reduced the burden on their clinical staff, and also has been showing excellent outcomes for their patients who are on it. So can you give people just a really quick rundown, what are the primary options, the main options that individuals with OUD have to access, and really how do they differ from each other? Because, I sometimes people will use medication for opioid use disorder, but they're talking about one thing and not the other thing. And they both have a real, use, for treatment, but different uses, if that makes sense.
Sure. Yeah. No, I appreciate that. And if I don't go into the level of detail that you're looking for, please do let me know. But the good news is, as you pointed out, that we have several evidence-based treatment options. And so the right choice really depends on an individual's need, what their preferences are, and the circumstances that they're in. But at a very high level, and you identified them well, the three categories are methadone, which is a full agonist. So methadone is a full agonist that typically is dispensed through specialized treatment programs and is usually taken every day. And then there's buprenorphine, which is a partial agonist that can be prescribed in a clinic and is available through any pharmacy. Some people take it daily, but as you mentioned, now that there's newer long-acting formulations of buprenorphine that can be administered weekly or monthly. And then finally, naltrexone, which works differently. It's an antagonist, so rather than activating opioid receptors, it blocks them. And it can also be given as a long-acting injection. But what's most important is that all of these options have helped people recover and to stay alive and live their lives. The goal isn't finding what's best universally. It's more about finding what fits best for a particular person at a particular point in their recovery journey.
So, and then for folks who just aren't familiar, like where can they encounter this type of care? Because I think people will most typically think of just an addiction treatment center, right? But I think that their options are more these days and actually quite scattered, right? You've got hospitals, emergency rooms, telehealth now. Of course, your standard brick and mortar treatment centers, and then of course in the criminal justice system.
Yeah, absolutely. You're so right. They're kind of scattered all over the place. So not only do we have to provide treatment options to meet someone where they're at in their treatment journey, but we literally need to provide adequate physical access to treatment to meet people where they are located. So it is in a variety of treatment settings, from inpatient and ER to a whole host of possible outpatient treatment settings, as you mentioned, treatment centers, but even pharmacies, mobile treatment services. And then you mentioned the criminal justice system is important too. And it's a matter about finding a way that we can provide continuity of care between these scattered treatment sites.
Yeah. And the justice system is really, where I believe all the gaps tend to collide, all at once. So let's talk about jails and prisons for a couple of minutes here, because this is the part of the conversation, honestly, that keeps me and many of my colleagues in the advocacy space up at night. We've got this whole population of people, who are by definition a custody of the state. And a huge share of them are, walking in with an untreated but treatable, potentially fatal disease. So set the scene up for us for a moment. When we talk about, OUD inside the criminal justice system, how big is this population? How many people are we actually talking about?
Yeah, it's bigger than one would think, I think. Roughly 1 in 5 people in our nation's jails and prisons are living with opioid use disorder. And so that means hundreds of thousands of individuals are affected in the criminal justice setting, and making this one of the most important opportunities that we have to identify OUD, to start evidence-based treatment, and to help people support the recovery.
So like the obvious question though is actually, are they getting treated? Like, is this actually happening behind the walls? What does access for someone who is in the CJ system actually look like?
Yeah, so this is something I'm actually very concerned about, is the consistency of access to treatment. So today, whether somebody receives evidence-based treatment or not can really heavily depend on where they're at when they're incarcerated. Some facilities have embraced medications to treat opioid use disorder and have integrated them into care very well, but others offer little or no access at all. So current data suggests that about 42% of facilities lack access to these FDA-approved medications. And even in facilities that technically provide the treatment, many of the individuals who are eligible for it never receive it. So actually fewer than 10 to 20% receive these medications. So it represents a significant opportunity for us to make a change and help save lives.
Yeah, absolutely. And like for me on the advocacy side of it too, I think that's crazy, right? Because the inconsistency is just maddening, right? Like it's like, what in your opinion makes one facility a place like, I think, even in Indivior's hometown, Chesterfield, Virginia, many of you may not know Indivior is headquartered in Chesterfield, but almost all of you who follow us and been with us are very familiar with the HEART program in Chesterfield, Virginia, right? So like what makes a facility like Chesterfield be able to exist, and then you go, down the road one county up, and it feels like it's a complete dead end in that jail.
Yeah, no, and you mentioned an amazing program in Chesterfield, but whether a person receives evidence-based treatment can depend on the state that they're in, if it's a jail or a prison, if it's rural or urban, do they have staffing for it? What are the leadership attitudes associated with treating opioid use disorder? Do they have contracted healthcare resources and policies that surround the treatment of opioid use disorder? So a whole host of things.
And I'll give you a quick story on my end. 2 years ago, I think 3 years ago, legislative session, state of Nevada, which is where I live. I live in Las Vegas. We were fighting for a series of OUD bills in the state legislature. And one of them I thought was like a no-brainer because I came from like the school of Carl, Sheriff Carl Leonard, right? in Chesterfield, Virginia, where every sheriff wants to, implement an OUD program and should want that because it's, data shows it leads to less recidivism, and it's better for the community that people are actually getting better. And we had bipartisan support on the bill where we actually ran up against the roadblocks were with some of the sheriffs in some of these rural counties.
Yeah.
And it wasn't because they were adverse to it. Really, what they were, their big issue was it being mandated and then there not being the support for their jails to actually implement something, right? That was meaningful. So the treatment and breaking those barriers to get the treatment access is important, but it's also equally important that we're providing the sustained funding needed to support longer term, more robust programs and bringing in the clinical experts behind those walls so that it can be done, be done right. And, I think a lot of this has led me to believe, and to know actually that one of the most important parts of treating OUD behind the walls is actually the reentry, right? Those first days and weeks and months when someone's released, it could be one of the most dangerous windows in a person's entire life. If you could walk folks through what happens to the body, when someone's released from jail and doesn't have that access to the MOUD when they get out, and why that moment tends to be so deadly.
Yeah, no, I appreciate it. It's extremely important. So we know that the overdose risk is roughly 40 times higher than the national average in those first 2 weeks post-release. So that's really staggering. And the reason for this is that during the time of incarceration, a person's tolerance for opioid changes, right? It reduces over time when they're not exposed to them. So when they're released and they return to their previous doses that they were on before incarceration, the results can absolutely be fatal.
Yeah, and oftentimes people are released with nothing, which is the very moment that we should be handing someone their, strongest possible protection. we're oftentimes sending them, out the gate with nothing. And I think that's a fair way to put it, so I want to name something, directly, because I think a lot of listeners, particularly those who are involved in the advocacy on both the recovery side and the criminal justice side, is that there's this mindset in some corners of the system and also many corners in society that says that people who are incarcerated somehow don't deserve a fair shake and good standard of healthcare when they're released. How do you answer that to folks both morally and practically?
Yeah, I'm very passionate about this. So people do not lose their right to health care when they're incarcerated. And Indivior believes that incarcerated people deserve access to drug treatment, including the long-acting injectable products, because opioid use disorder is a chronic and treatable, as you mentioned, medical condition, and it's not a moral failing. We have evidence-based treatment that works during incarceration and during reentry and will reduce overdose risk. It will help people stabilize. It will improve reentry outcomes, help people reconnect with their families, to pursue employment, reduce the likelihood of relapse and recidivism, and it's the right thing to do. And it advances a more compassionate and effective public health response to this disease.
Yeah, I was, so last week I was on the phone with our friend Sheriff Leonard in Chesterfield, and we were talking through some of the new programs he's looking to implement there. And he had brought, Dr. Gay, his medical director, on, and a couple of the folks that work in the heart program there. And people do, when they go into the jail there, whether it's for a couple weeks or a couple months, they lose access to their Medicaid. There is no financing system to provide for their support, their healthcare support. And I think universally, we were all in agreement that is one thing that I think is crazy and needs to change. But I also think it's probably important, in order for us to get to that place, to make this, like we were talking before, that economic argument, one that reaches people from all walks of life and all, political stripes, reaches them where that moral argument doesn't always reach, and really reaches them in the pocketbook. So, what is the actual cost of getting this wrong in the justice system? When we fail to manage opioid use disorder in jails and prisons, what does that cost the American taxpayer?
Yeah, it's a good point. So beyond the human toll, as you mentioned, there's definitely a significant economic impact to leaving opioid use disorder untreated. One estimate that we know is that the failure to adequately manage opioid use disorder in jails and prisons can cost taxpayers about $52 billion annually. That's about $44,000 an inmate.
$52 billion a year. I mean, that is a big number for folks to swallow. When you start aggregating, these numbers, it's just, again, it's almost too big to believe.
Yeah.
And, you talk to sheriffs, you talk to folks who work in the system, wardens, corrections administrator, the people who run these facilities, and many of them are frustrated, and they see the barriers, that exist every day. So what do they tell you? What do you hear mostly that those barriers happen to be for folks who are helping manage these systems?
Yeah, so we do have many interactions with people that are leading these facilities, and we've done research, and we know that they consistently tell us that their primary barriers to offering medications to treat opioid use disorder revolve around inadequate staffing and a fragmented care system, including inconsistent adoption of the evidence-based practices, as well as clinician shortages. But really, the main point is that nearly 50% of U.S. jails report that inadequate staffing is their primary barrier.
Right. And this is like where, so, and again, like not to keep bringing in stories, but like we had this, literally Garrett and I had this discussion yesterday, at a facility, and they were talking about the staffing, and really the staffing, how is a huge barrier to being able to add, programs. Usually we hear we can't afford to add the program, but it really sounds, and it's sounding more and more like a big barrier is just the sheer, daily labor of certain kinds of treatment that exists.
Yeah.
And this is where I get excited because, science continuously evolves. New options come to the table, and there are options that are now coming to market that really change the math completely. And I think that that's, a good bridge for us to spend kind of the latter part of our conversation, which is these LAIs, long-acting injectables, and really how they've changed the game, and how they can change what's even possible, within regular brick and mortar treatment facilities, but also, criminal justice system. So let's, demystify it for just a second.
Sure.
Long acting injectable buprenorphine is a mouthful, and I want people to understand and actually internalize why this is such a massive breakthrough, and a big deal, especially in a jail setting. So if you could start simple with our audience, what is long-acting injectable buprenorphine? How is it different from the daily form of the film dosing or the tablet that most people think of when they think of, Suboxone or buprenorphine?
Yeah, absolutely. It is a mouthful. So long-acting injectable buprenorphine, or sometimes we abbreviate LAIs. It's the same medication that people
By the
know.
way, we call it the shot.
The shot.
The term that we're talking when we talk to here is like, are they getting the shot? So I'll just throw that out there.
Gotcha. Yeah. Well, so it's the same medication that many people already know from daily films or daily tablets. It's just delivered in a way that lasts for an extended period of time, either a week or there's a monthly version that is administered subcutaneously, which means that it's simply an injection that goes under the skin, and it slowly and consistently releases medication, which is in this case is buprenorphine, over a period of time. So instead of taking a medication every day, a person receives an LAI or the shot, and they get a sustained amount of buprenorphine over a period of time.
Which, let's just put it into context for folks, right? So instead of 365, daily doses or possibly more, per year, we're talking roughly 10 to 12 doses a year, which is a big drop in touch points,
exactly.
for folks. So I think let's connect this back, to that terrifying reality that you brought up earlier, that 40 times number, higher overdose risk, for folks who are coming out of the criminal justice system. So if someone is getting monthly injection shortly before they're released, what does that do for them during those first dangerous weeks on the outside when their life is really just kind of in chaos and, daily pharmacy visits, might be the last thing that they can actually pull off?
Yeah, absolutely. Yeah. As you said, that period immediately following release is among the highest risk time, but it's also total chaos. People are trying to find housing, reconnect with family, secure employment, get their insurance coverage back, right? Arrange for transportation, reestablish with healthcare, all of that all at once. So it's a very difficult and challenging time. So if somebody can receive a long-acting injection before the release, then they are leaving with a consistent level of buprenorphine that's already in place during that critical time. And they don't have to immediately try to navigate getting a prescription filled or worrying about how they're going to maintain their treatment while they're managing everything else that goes along with that same period of time. So I think that consistency is an important source of stability during a time when everything else is anything but stable.
So, and this is more in general, not just the criminal justice system, but treatment retention is a term that's often used, right? And it comes up constantly in the recovery space. People, that are falling out of treatment. How do LAIs and these injectables, or as I like to call it, the shot, really changing the scope for the retention picture?
Yeah. No,
how is it helping folks to stay involved in their treatment process?
Yeah, I think it's a good question. And I think if we look at retention as being a really important part of recovery, because recovery is a journey, right? It's not a single event. So long-acting injectables, while they don't remove all of the challenges that are associated, particularly with reentry, they can help create some continuity when their life is already very disrupted. The medication is already on board, is providing consistent levels of buprenorphine, and treatment can continue in the background while a person can then focus on rebuilding their life. So what that might mean in practical terms is having fewer opportunities for treatment disruption, right? During that critical first weeks after release. So instead of immediately having to coordinate daily medication access, they focus on connecting with healthcare providers and housing and employment and those other things that help contribute to long-term recovery. So I think it's really important to look at treatment retention, not about keeping somebody just on a medication, but it's about keeping somebody connected to recovery.
And I was looking at some of the numbers too. And you probably agree with me on this. It's you oftentimes will hear when we're talking about the opportunity for the shot or long-acting injectables, people think about they'll have sticker shock or they'll think about, the pricing and administration. Yeah. And if you really look at the overall picture, right, the capacity that it takes, oral buprenorphine versus LAIs, you're actually saving time and you're saving money in the long term.
Yeah.
And I think one of the big issues that also comes up that this helps, and I've been talking about this for, it's 2019. I mean, so going on like 8 years, is the diversion issue.
Yeah.
Right? LAIs helps to reduce, if not eliminate, diversion in many cases. Is that accurate?
Well, so what we know is that LAIs do definitely offer a very practical and evidence-based solution that have great patient outcomes. But the benefit of LAIs, in addition to that, when you talk about diversion, is the fact that they have to be administered by clinical staff and they can't be stored or handled by a patient.
Mm-hmm. Got it. So do you think that we're moving into a world of more utilization of LAIs, and what are the real world hurdles that are keeping us from implementing this more wide scale right now?
Well, I'm hopeful that we're moving into a world where there's more access to long acting injectables, but I would say, facilities have to have a champion, right? In order to get this right, they are going to need somebody that can manage the logistics of putting a program in place to help with medication administration, to find available funding for the long-acting injectables. It's not complicated, but it does require planning and definitely a belief in the value that this treatment provides. So essentially, that's the catch to what these wonderful treatment options are. You have to have a champion who has the will and the means to help manage the logistics.
So what does good implementation look like? And also, I don't know the actual clinical term for it, but like here in Nevada, there's certain sites, I guess, that if someone is prescribed an LAI that they can go to and that it's actually administered. And I wish I had it in my notes. I don't, but like one of the advocacy pieces I had somebody ask me for yesterday is like, we should talk to these pharmaceutical companies and the state about more access to sites where people can get their LAIs administered.
Yeah, no, I think that that's a great point. And I think maybe the term you're looking for is alternative sites of care, or I've heard other things, but
ASCs, that's it. Yes.
Yeah.
Yes. Yep.
Yeah. So really it's an opportunity because some clinics don't even offer patient exam rooms, right? When it comes to addiction medicine. And so these alternative sites of care are sometimes in pharmacies. So they're very
I was just going to spitball with you for a second. Cause like, and I'm sorry for cutting you off, but this is where I get like all hyped up. I mean, and I'll go around and say like, when COVID happened, like we were able to like deploy a vaccine in like real time, and Operation Warp Speed's what they called it. And you could go into any pharmacy in America and get your vaccine, and you can still get your vaccines today. So like, what's stopping us from that model where people can get their LAI prescribed and you can go to your quick clinic at CVS or Walmart or Walgreens and go into have a nurse practitioner that's able to administer it right there.
Yep, you're absolutely right. And, I take a lot of pride in the practice of pharmacy as a pharmacist myself. And I think it's a really good opportunity. And we just need to make sure that all state laws can help accommodate that, because there are certain states where it's permissible and other states where it's not.
My God, so this is like the part where I really want people to know that this is where they can have a hand in helping, because at Mobilize Recovery, this is our whole purpose, right? This is why we exist. It's about turning this understanding into real action. So let's talk about that policy for these last few minutes that we have and talk about where the fight actually is right now. Because you just mentioned the map, right? The most recent data that we've got is, there's only about 16 states that require access to the medications in correctional facilities. But that means that a majority of states still have no such requirement. What does this patchwork mean for a real person? And depending on which side of a state line they happen to be arrested.
Well, to me, what that patchwork map means is that access to evidence-based treatment can really depend on geography rather than medical need. Yep. So two people with the same diagnosis, the same desire for recovery, the same risk of overdose, can have very different experiences depending on where they end up in the criminal justice system. So in some states, you have access to medications for opioid use disorder, and it's becoming more part of their routine care. But in other states, access is very inconsistent. So to an individual person, that can mean the difference between leaving incarceration connected to treatment and recovery, or leaving without those resources being in place. So it's challenging because opioid use disorder doesn't change at a state border, right? The disease is the same. The risk of overdose is the same. The need for treatment is the same, yet access can look very, very different depending on
that's for folks behind the wall, right? Let's talk about for folks out in our communities, right? And we were just talking about the LAIs and being able to get them implemented in, quick clinics or minute clinics.
Yep.
And you made mention that we can't utilize this in every single state right now. Like we couldn't implement this if we wanted to today.
In certain states. So, when it comes to talking about minute clinics where there is a healthcare provider, that's not going to be an issue. But if we look at more broadly at community pharmacy and the ability for pharmacists to give those injections in some states, because it's a controlled substance, there are more limits than others. But I think that that's something that states are working and need to work toward, is to have broader access.
If there's a state you could put, I don't want you to play favorites, but is there like a model state right now that's actually implementing this, or is this all new?
Well, I'd say that, there are several states that are ahead of the curve in terms of allowing pharmacists to do administration. But what I take great pride in is that there's states, and I know the state of Oregon is one that's working to implement this, and I believe the state of Idaho already has, where pharmacists can actually help in the diagnosis and treatment prescription of medications for opioid use disorder. So it's going beyond just a site for administration, but it is an actual site for care.
So what actually moves policymakers' feet, do you think, the most? Do you think it's the moral case? Do you think it's the money? Is it the public safety angle? Like what lands most with them?
Yeah, I think it's all of those things. I think it's the moral case. I think it's the money. I think it's public safety. I think any of these things can move lawmakers and decision makers in this space, but everyone probably has a little bit of a different calculus in terms of what actually drives them toward action. I would say health economics, the impact to communities that they serve, public safety, and the hope for reduced recidivism are definitely some of the chief drivers.
Yeah. And I think, in my experience too, the economic argument's always very, very helpful, right? So I want to put like the strongest possible version of that economic argument at the tail end of this conversation on the table, because I think it's genuinely staggering, and most people have probably never heard of it. And there's a number that I keep seeing, and it's studies that are showing that like when you combine the medications, specifically long-acting injectables, LAIs, or as I like to call it, the shot, with behavioral therapy, there's studies out there that show that it's something like $295,000 in savings per patient per year. And again, another really big number. If maybe you could walk our advocates through it, how you get to that number.
Yeah, definitely. And I'll just emphasize again the fact that you said it's per patient per year savings. We're not talking about like a facility. We're talking about per patient savings. Right. So yeah, it's a combination of factors that add up to that total amount of savings. So if we look at behavioral therapy alone, that saves about $144,000 per patient per year. But then you tack onto that the value of adding medications for opioid disorder. And if we look at daily treatments, that number's up to $271,000. But the greatest economic benefit is when we combine behavioral therapy with a long-acting injectable. And we see the total savings number up at the $295,000 per patient per year savings that you mentioned. And it comes really from four different categories of savings that I think are important. So it's healthcare costs. That's probably the no-brainer of the group. It's from criminal justice cost savings, the cost that there is from lost productivity. And then finally, but I think most importantly, the patient burden costs. So that's quality of life issues, life years lost, that sort of a thing.
So in closing, if you had a couple minutes in a room with every governor and every state legislator in one of these states that we're brushing up against right now that we could do better in, what's one thing you would want them to walk out understanding about MOUD and specifically around LAIs?
Yeah, I really want them to understand the value of treatment and that it's essential, and that long-acting injectable buprenorphine can save money as well as provide people with better outcome. So the investment to remove barriers to access is critical.
Absolutely. So I could keep going on forever. I love talking about this stuff. It gets me real excited, but we are running out of time. So if people want to learn more and about the work that you all are involved in, the new science, particularly around LAIs, is there a place that they can go to get more information?
Yeah, absolutely. I mean, I would encourage people to seek out some credible evidence-based information from a variety of sources. Would love if people would stay engaged and listen to people that have lived experience through advocacy organizations like yours. But there are a lot of great organizations that are working directly with people that are affected by opioid use disorder. Government agencies like the National Institute of Drug Abuse, Substance Abuse, and Mental Health Services Administration. A lot of opportunity to get engaged with a whole variety of educational resources. I think Mobilize Recovery, if I can say that is an outstanding resource for information. We would absolutely love if people followed along with Indivior.com at Instagram or LinkedIn to learn more about the work that we're doing. So I think there's a lot of opportunity for people to find more information and to please get involved.
And thank you so much for your time. Thank you for the partnership, the strong partnership that we've got with Indivior. This is exactly the type of conversation that Operation Understanding exists for. It's not just a slogan, but there's real mechanics around the things that keep people alive and help them get better. One of the things I keep hearing, underneath all of this is a pretty simple, idea, right? And that's that this is a treatable disease, that the tools are there, and whether somebody gets to use them or not shouldn't come down to what door they walk through or what, state line they happen to be within or standing behind. I truly believe that we can close this gap and that we must close this gap. So thank you for all of your work, and for everybody that's joining us and listening in. Thank you for joining us on this journey. Remember, it's important to take care of yourselves, to take care of each other, and we'll see you out there soon. Thank you, everybody.